afternoon, respectable the Chairman of Obstetrics and Gynecology Department, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Dr. Ardanu Kusumanto, OBGYN Oncology Consultant. Honorable distinguished speakers, Dr. Sofal Widat, OBGYN Reproductive Endocrinology and Fertility Consultant, Dr. Inmed Elizabeth Reiser, our moderator, Dr. Sarah Ayu Andari, PhD, OBGYN, and all the respectable participants of this event. Welcome to the OBGYN webinar series with Innsbruck Medical University, Austria, with the topic of current standings of fertility preservation program in the world. Where are we at the moment? Held by Reproductive Endocrinology Division, Department of Obstetrics and Gynecology, Universitas Gadjah Mada. I'm Regina Arumsari, the MC of this event. On behalf of the organizing committee, we extend our appreciation for your presence today. Thank you to the Almighty God who has given us blessings so that we can attend this meeting without any troubles and obstacles. Dear audiences, before starting the session, I would like to remind you that all participants who are joining the session may ask questions by writing down the question in the chat box that has been provided. Participants may also raise hand and wait patiently until the moderator admits to join the discussion. All participants may also start to fill out the Google form that has been provided in the chat box. Please give a full name along with the title and active email to get a certificate that will be sent after the event is over. Dear audiences, ladies and gentlemen, before starting the session, I would like to give the stage to the head of Obstetrics and Gynecology Department, Universitas Gadjah Mada for the opening remarks. To Dr. Ardanu Kusumanto, OBGYN Oncology Consultant, the time is yours.
Thank you, Dr. Regina. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon to all respectable participants of today's seminar, our respectable teachers and colleagues, our guest of honor and our speaker, Dr. Elizabeth Reiser, Dr. Sofal Widat, our moderator, Dr. Sarah Ayu Andari, and also our beloved students and guests. First of all, let's pray and say thanks to our God, Allah Subhanahu wa Ta'ala, who has been giving us blessings so we can attend and gather in today's event. Today's event consists of two topics of discussion. First is about translation phase of building a fertility preservation program delivered by Dr. Sofal Widat. And the second topic is about current standings of fertility preservation in the world, given by our honorable guest speaker, Dr. Elizabeth Reiser. We would like participants to be active during the discussions. Hopefully, today's event will give us better insight about the updates of fertility programs. Without further ado, I open today's seminar by saying Bismillahirrahmanirrahim. May today's event run smoothly and brings new knowledge. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Ardanu, for the opening speech. For the next agenda, we would like to proceed to the main scientific session. This session would be moderated by our moderator, Dr. Sarah Ayu Andari, PhD, OBGYN. Please allow me to introduce Dr. Sarah. Dr. Sarah received her PhD in Innsbruck Medical University in 2016 with a research topic in fertility preservation. She has published many research in fertility preservation area, with the latest is about fertility preservation in girls and adolescents who underwent cancer treatment. Without further ado, please welcome our moderator, Dr. Sarah Ayu Andari, PhD, OBGYN. Dr. Sarah, the stage is yours.
Thank you very much, Dr. Regina. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, Professor, doctors, colleagues, and also students. I am Sarah Yohandari from Department of Obstetrics and Gynecology, Universitas Gadjah Mada. And today we are very glad to present the first webinar series between UGM and Austria in OBGYN department. We actually arranged this webinar in order to strengthen the relationship between UGM, especially also between Jogja and Austria, and also one part of Austria that has been part of our relationship before is Innsbruck Medical University. Today we have two distinguished speakers that will share to us how actually the fertility preservation program is established nowadays in our two very different settings. Because Austria, we know that it is one of the developed country in Europe, and Indonesia is one of developing countries in Asia. And this topic in fertility preservation is quite challenging and also is objected to be developed in the future. We really encourage the participant to be active, and also if you have questions, please just use a raise hand feature in Zoom meeting application, and also you can also write it on the chat box. First of all, I would like to greet our speakers. The first one, Dr. Elizabeth Reiser from Innsbruck. Hello, Elizabeth. Good afternoon.
Hello, good afternoon.
Hello, how are you?
I'm great, and I'm very grateful for the invitation.
Yeah, thank you very much for being here today. And is it already summer, I think, in Austria,
yes,
right?
Yes, is the hottest days of the summer, apparently.
Yeah, okay. So before we hear your talk, we would like first to hear a talk from our department. And we have here Dr. Sofwal Widat, OBGYN consultant from Division of Fertility and Endocrinology Reproduction. Hello, Dr. Sofwal Widat.
Hello, Dr. Sarah.
Yeah, how are you, Doc? Good afternoon. Yeah. First of all, I would like to read Dr. Widat CV. Okay. Yeah, Dr. Sofwal Widat's interest is in reproductive endocrinology and fertility, and of course, he is also a very well-known gynecological laparoscopic surgeon, and his latest education is in reproductive endocrinology and infertility, also in this university. And at the moment, his affiliation is as the head of reproductive endocrinology and fertility division. And also he already published several publications. One of them is about the vitrification of ovarian tissue, and it was being transplanted on the chorionic allantoic membrane of the chicken. Okay, Dr. Widat, today Dr. Widat will present about the translational phase on building fertility preservation program. To Dr. Widat, the time is yours.
Thank you, Dr. Sarah. Good afternoon for all participants. Can you hear my voice clearly, Dr. Sarah?
Yes, very clearly, Doc.
Okay, thank you. Okay. In this moment, I would like to present our presentation about translational phase of building a fertility preservation program. And for introduction, I think we have known that cancer on childhood was increased, and also in group 15 until 18 years old, increased until 20 times fold. And also we have also know about the increasing incidence of cancer in young women. And on the other hand, I think the improvement in chemotherapy and radiotherapy of the cancer, the survival rate was increased significantly. And in the other hand, we also know about the effect of cancer therapy on ovary that have been gonadotoxic effect. And cancer therapy is associated with risk of premature ovary insufficiency and also infertility. So in the past, maybe the patient that diagnosed as cancer, maybe only one hope to survive. But nowadays, I think the expectation was increased after the patient survived. The second problem is maybe question arise about the fertility in the future. So I think we also know about fertility preservation method in female, and there are some method in female fertility preservation. The first that maybe very established is embryo cryopreservation and also oocyte cryopreservation. But the problem is in both of the method, it's not appropriate for maybe a prepubertal girl. And I think it's new news about ovarian tissue cryopreservation. Since 2019, American Society of Reproductive Medicine published that ovarian tissue banking is an acceptable fertility preservation technique and is no longer considered experimental. But however, in many countries like developing countries such as Indonesia, ovarian tissue cryopreservation is still challenging, like Dr. Sarah said before. This is about the history. This is a history about the success story of first live birth in tissue frozen cryopreservation. And the patient was taken ovarian tissue before puberty. And in 2016, after transplantation, the patient succeed to pregnant and until deliver her baby. And behind the success story, I think we have to learn about the success story. If we want to develop a fertility preservation program, we have to vision and commitment. We have to make organization and team building, and also we have make interdisciplinary collaboration, education and training, and also we have to doing translational research. And I think it's learning from developed countries' experience, like I present in this presentation from Belgia group from Professor Dolmans et al. This is published in Human Reproduction in 2017. Professor Dolman and group do until 500 cases of ovarian tissue cryopreservation in his hospital. And we know about the publication that the death incidence is until 10%, and only 4% of the ovarian tissue cryopreserve, transplantation again and retransplant again to the individual. And after 6 years of ovarian cortex ovarian cryopreservation experience, Professor Dorman et al. Started doing the first ovarian cortex auto-transplantation. And very small proportion of ovarian cortex auto-transplantation compared of total fertility preservation procedure, almost 4%. And this is what activities that maybe to initiate fertility program in our division and our department. We start in 2017. We have the building interdisciplinary cooperation with oncologists and also radiologists and also other discipline doctor. And also we perform and we also invite the expert in ovarian tissue cryopreservation. This is Professor Kawamura from Japan to supervise protocol for ovarian tissue cryopreservation in our laboratory. And also we also went to the workshop in overseas in New Delhi for a workshop on ovarian tissue cryopreservation in Asian Society of Fertility Preservation in 2018. And this is about the translational bridge in fertility preservation concept. As we know, translational research is a translational bridge for outcoming the gaps between basic and clinical research and clinical practice or services. And in fertility preservation, to achieve the first live birth, we have many process from animal research and clinical trial, so the success will overcome. And for the first, maybe we can also translational research in basic research starting from animal model. And in fertility preservation, we also need to evaluate the development of ovarian tissue following vitrification procedure. Maybe we have some option for research as a model. The first, maybe we can choose the animal model for xenotransplantation. In this model, we can assess the follicle development and ovarian function. But maybe, unfortunately, maybe potential rejection maybe can arise. And the next model, maybe we can also choose the in vitro culture. It is possible to assess follicle survival, but it's impossible to assess the angiogenesis process. And we also developed the model for transplantation in our department. We use chorioallantoic membrane of the chicken. This is maybe have some advantages like lymphoid immunity is still not developed early. So this model is immunodeficient, and the structure of chorioallantoic membrane mimicking the peritoneum structure and in vivo. And we also assess the neovascularization after transplantation. I think in the developed country like Austria, maybe they have more ideal animal model like STID mice. Yeah, I think this is a paper from Dr. Sarah in Innsbruck Medical University, Austria, and this is maybe very ideal for fertility preservation research. But I think in the developing countries, maybe it's difficult to develop the research like that. And this is some step that we have developed in our department to initiate the fertility preservation services in our hospital. We start with animal model in goat ovary, and also nowadays we go to human ovary as a subject of research. This is some research in our department. We have do the research in follicular localization in ovary, and also primordial follicle survival of good ovarian tissue after vitrification and transplantation on chorioallantoid membrane. And also we search about ischemic injury post-transplantation and so on. And beside the animal research, we also do the research in clinical setting. This is a paper from Dr. Sarah about current awareness and attitude toward fertility preservation in Indonesia. And this is about an animal model in goat that have published in Middle East Fertility Society Journal in 2020. And this is, I think, our recent research, optimization of ovarian cortex size that undergoing vitrification and transplantation, crosstalk between P10 AKT pathway and hyposignaling pathway. We know about the signaling pathway, PI3K and ACT signaling pathway that will induce the activation of follicle primordial become to growing follicle. This is very we know about growth factor that include and involved in this pathway, and also we also know about the another pathway, hyposignaling pathway from Kawamura. Physiologically, most of ovarian follicle growth were inhibited by hyposignaling pathway, but mechanical manipulation like tissue fragmentation can induce and disrupt this hyposignaling pathway. So this is very important to know for us to develop fertility preservation like ovarian tissue cryopreservation. As we know that smaller size of cortical ovarian cortex, maybe smaller size will be better perfusion in the vitrification procedure. So this can inhibit the cell damage due to ice crystal. And according to Galvis et al., we have also know that smaller size maybe can inhibit ischemia and maybe increase oxygen diffusion and growth factor. So maybe this better in neovascularization after grafting. And maybe this is important to know about ovarian tissue fragmentation, that fragmentation to smaller size can be disrupt hyposignaling pathway and can induce follicle growth post-transplantation. And beside that, smaller size amount of primordial follicle may be less in and maybe can overcome short duration of fertility age after transplantation. And this is the aim of research. We try to know about maybe divided the ovarian cortex into two sizes, 0.4 centimeters and 0.8 centimeters. And we investigate about angiogenesis following transplantation that we assess by immunohistochemistry of anti-CD4, and we have also observed about percentage of viable primordial follicle following transplantation, and we also assess the follicle apoptosis by observe the immunohistochemistry expression of anti-Cas3, and we also explore about activation of primordial follicle like immunohistochemistry of primordial anti-Ki69 and also anti-X and also anti-FOXO3 and YAP and CCN. This is a quasi-experimental study with post-test only control design. This is our inclusion exclusion criteria. We determine and exclude the history of chemotherapy and radiotherapy of the patient and also menopause from this study. And the patient we determine with age 18 until 40 years old and undergoing laparoscopic or laparotomy surgery, and we have also assessed for anti-Mullerian hormone level. This is our research flow from ovarian cortex tissue preparation, and we do fragmentation into 0.4 and 0.8 centimeters, and we divide it into fresh control, fresh vitrification, and vitrification and transplantation. And we assess about 8 parameters to assess the percentage of viable primordial follicle, immunohistochemistry for angiogenesis, apoptosis, proliferation, and activation of FOXO, activation of PI3K pathway and also hyposignaling pathway. This is for description for our study. Upper ovarian tissue sample we obtain from the patient. We prepare and fragment to small size, and we go to the vitrification procedure, and after that after thawing procedure, the tissue transplant onto chorioallantoic membrane, and after 5 days of transplantation, we do harvest and assess 8 variables. This is the characteristic of subject in our patient. There are 6 subjects that diagnosed as ovarian cyst, benign solid ovarian tumor, ovarian endometrioma, cervical cancer, placenta accreta, and mastoteratoma. Yeah. And this is our result. This result about immunohistochemistry expression of marker of angiogenesis in vascular endothel in ovarian cortex. And in the graph, we can demonstrate that smaller size is better in angiogenesis and neovascularization compared to larger size. And for assessment of follicle, primordial follicle, viable primordial follicle, we can also observe that small size is better in viability after cryopreservation and vitrification in our result. And for variable immunohistochemistry of apoptosis, we also see in the graph that smaller size is better than larger size in process of apoptosis. And this is the result of immunohistochemistry of proliferation marker with by anti-TI67 for marker. And in the result, we can see that smaller size is also better than large size for ovarian tissue cryopreservation. And for activation, this is a phosphorylase immunohistochemistry to assess the activation of PI3K pathway. We can also see in this graph that smaller size of cortical ovarian cortex is better than larger size in ovarian tissue cryopreservation. And this is about anti-YAP immunohistochemistry expression that can represent the hyposignaling pathway. And in this graph, we can also see that smaller size is better than larger size. And the last, this is about graph of expression immunohistochemistry expression of anti-CCN2 on granular cell. We can also see in this graph that smaller size is lower than larger size. So I think I want to summarize this study that if we have to choose about size of cryopreservation tissue of ovary, both of them, small size and large size, have maybe considered advantage and disadvantage. Small size give advantage for better survival of graft, but maybe disadvantage in more activation of primordial follicle. And larger size maybe give us the advantage about less activation of primordial follicle, but maybe survival of graft, I think less than small size. And this is about advantage and limitation of our result. For advantage, this is the study using human ovarian tissue, and we choose transplantation on chorioallantoic membrane that is immunocompromised, and we can observe the reperfusion and angiogenesis. But we have also some limitation of the research that subject and characteristic may be not ideal, and maybe in our subject have low follicle density, and we only can observe until 5 days. This I think very short duration of observation following transplantation of ovarian tissue. Thank you. This is maybe some of our team in fertility preservation. Yeah. Thank you, Dr. Agung. Thank you, Dr. Sarah Ayu Andari, that may be involved in this research.
Okay. Thank you, Dr. Widat. Thank you very much, Dr. Widat, for a really comprehensive talk, and it's really nice presentation regarding our current research. And for the audience, let's give Dr. Widat virtual applause. Okay, before we start the discussion, now we welcome our main guest speaker, Dr. Rinmet Elizabeth Reiser. I can call her Elizabeth. Hi, Elizabeth.
Hello.
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 Yeah. Okay, firstly, I would like to introduce Elizabeth to the audience. Elizabeth was born in Germany, and at the moment, she is employed in Department of Gynecological Endocrinology and Reproductive Medicine in Innsbruck Medical University, Austria. And her publications, I read a lot of publication about fertility preservation, and it's also nice to see at this year you have published in Cells. Yeah, congratulations. It's about ovarian damage after low dose radiation, and also several publications regarding gynecological cancer and gonadotoxic treatment. And you also have received the prize regarding fertility preservation. I think it is related to your publication in Cells, right? Okay, to Elizabeth, please, the time is yours.
Okay, I will share my screen.
Yes, please.
So I hope everybody can hear me and see my slides.
Yes, clearly.
Okay, so thank you very much again for inviting me. I'm very honored. Unfortunately, Dr. Sarah and me didn't get to meet while she was in Innsbruck because back then I was still employed in Vienna. So I'm going to talk about current standing of fertility preservation programs in the world, and we have to look where we are at the moment. First, I want to show you where I live and work. So that's a map of Europe and that very tiny country, Austria. We have only 8 million inhabitants. This is us, and here you get a closer look. So Austria has, as I said, 8 million inhabitants, and Innsbruck is located in the mountains.
Sorry, Elizabeth. I think you haven't shared the actual screen, so it's still in the title of your presentation. Slide? Yeah.
Okay, because I'm seeing my third slide already.
Not yet. Now it's third slide.
Now?
Yeah.
Okay, so you see the map of Europe.
Innsbruck map.
Yes.
Where is, yes.
So,
yeah.
Once again, that's a map of Europe, and the red dot is Innsbruck, which is in the east of our country, and we're in the mountains. Okay, so let's start with a case. A typical patient which presents at our unit. She's a 30-year-old. She has no children so far, and she's living in a relationship. And she gets unfortunately
sorry, Elizabeth, it's still the map of Innsbruck.
Okay, then maybe we have just a lack of time because...
Okay. And it's still the layout of, how to say, not the slideshow,
like this?
slide out.
And now?
Now it's okay. Yeah, this is the case already.
Okay. And now you see also, now I can go forward?
Yeah, perfect.
Okay. It's a long connection to Indonesia, I guess. The case again, she's 30 years old. She has no children so far, and she's living in a relationship, and she gets diagnosed with breast cancer, which is invasive ductal, hormone receptor positive, and also HER2 positive. The size of the tumor is approximately 2 centimeters, and the planned treatment is to first administer neoadjuvant chemotherapy, then to perform surgery, and afterwards she should receive endocrine therapy. And how we counsel this patient and how she might be counseled around the world, we will talk about at the end of my talk. So I hope now you see the next slide.
Yeah.
Perfect. So I think now we are on track. Of course, we have first have to think when we perform fertility preservation. And this is for example, to patients with genetic predispositions such as Turner syndrome or Fragile X, and also to patients with a family history of premature ovarian insufficiency or failure. We also can offer fertility preservation options to patients with benign diseases, such as endometriomas, especially when they're on both sides of the ovaries and we have to perform surgery and we assume that the ovarian reserve afterwards is diminished. Also to patients who have autoimmune diseases or rheumatic diseases who will also receive afterwards gonotoxic treatment. Then in some countries, there's also the option of social freezing, and I'm very curious how you perform this in Indonesia and how it's legal or not illegal, but we will talk about this afterwards. And then, of course, we have the big group of cancer patients who are about to receive gonadotoxic treatment and who need fertility preservation options. And how also the former speaker showed is that, of course, we can perform fertility preservation options because treatment options increase and improve. And thereafter, also the survival rates of those patients increase. So here we see 5-year survival rates of young cancer patients between birth and 19 years old. And we see that the overall survival rate is over 80%, and in some cases it almost reaches 100%. We know that in medicine there is never 100%, but for example in Hodgkin lymphoma patients, which comprise a big group of patients, or Wilms tumor patients, it's almost 100%. So we have to also look at the cancer treatment options. They comprise typically surgery, radiotherapy, chemotherapy, and adjuvant therapies, or a combination of those. And all of these cancer treatments have an effect on the gonads, especially in women. We talk about the damage to the ovaries, which can lead to premature ovarian failure or insufficiency. And then further leads to infertility, or also to climacteric syndromes, osteoporosis, and the risk of coronary heart disease increase. So we also don't only have to look at the infertility or the child wish part, but also at the other part. When we talk about gonotoxicity, we have to look at the ovarian reserve. And this is defined by the primordial follicle pool, which is definite in every woman, highest before birth, around 5th month of gestation, and thereafter continuously declines until the woman reaches the menopause. And we know that cancer treatment can even speed up this progress. Also, here again, it's chemotherapy which speeds up this progress. And here, especially the agent plays an important role. Especially alkylating agents are very aggressive. The number of cycles or of a mono or combination therapy is applied. And also radiotherapy speeds up this progress. And here the dose and the radiation field play an important role. Now let's look again at chemotherapy and the different pathways where the damage occurs. We don't have to talk about this in detail, but I want to show that there's different moments where the damage applies. We have cortical fibrosis. We have oxidative stress and direct damage to the follicles by especially cyclophosphamide. We have reduction of the follicle pool by effects on the DNA, especially by anthracyclines. We have a loss of primordial follicles by apoptosis. Also, the cortical vessels are damaged by especially anthracyclines. And we have damage to the cytoskeleton, especially by taxanes. And here is the first time I want to show you a slide from the guideline of ESHRE of 2020 on female fertility preservation. And when we talk about gonotoxicity, they strongly recommend that clinicians should provide information to the patients regarding the impact of cancer and the treatments on reproductive function, other diseases and the treatment on fertility preservation options, and the issues related to cryopreservation storage after fertility preservation. And they also state, and that's why I put the slide here, that the risk of gonotoxicity should be assessed in all patients undergoing gonototoxic treatment. So that's a very strong recommendation. So when these patients come to our department, we first ask for their planned treatment, or we ask the doctors who send the patient, and we don't know all of the treatment options by heart, but we have these slides or slides provided by here, for example, of the ESMO guideline, where we know how strong the risk of a permanent amenorrhea is in female patients depending on their treatment. And we divide these treatment options into different groups. And we have the group of low risk, so under 20% risk of amenorrhea, intermediate risk, and high risk. And that's a very important information before we counsel a patient, that we know how high the risk of permanent amenorrhea is. The same table also exists for men, for treatment-related azoospermia in male patients. And here again, we divide the treatment options into high, intermediate, and low risk. When we look at the gonotoxicity by radiotherapy, and as you already said, this is the interest of my research, we know that also this comprises different moments of damage to the ovary by the effective sterilizing dose, damage to the fallopian tube, and of course damage to the uterus. And that's a slide, it is in German, but I will translate it. It's from the German, Austrian, and Swiss guideline. I will talk about this later on fertility preservation. And there we have a table, how high the effective sterilizing dose is depending on age. And we know that a younger patient can receive higher dose or dosage of radiation until really strong damage occurs, while older patients above 30 already lower doses lead to a permanent damage. So also here, the ESHRE guideline formulates a strong, or not a strong, recommendation. They say that pelvic radiotherapy without chemotherapy is planned, women can be offered ovarian transposition. We will talk about this later with the aim to prevent premature ovarian insufficiency. So how do we estimate the ovarian reserve? Of course, we use the AMH, the anti-Müllern hormone, which is produced in the small preantral follicles. And we also use the antral follicle count by performing sonography. So after assessing this, or after we know how to assess this, I just want to point out that there exist several international guidelines for fertility preservation. First of all, from the ESMO, it's a clinical practice guideline from the ESHRE of 2020. And here also in the German-speaking countries, which is Austria, Germany, and Switzerland, so around 100, not quite, but almost 100 million people, the German guideline. It is from 2017. And because I want to talk about the fertility preservation programs also, I want to point out at that time that we have a very strong and good fertility preservation network here in the German-speaking countries. It is called FertiProtect, and I'm also curious to hear afterwards if you have something like this in Asian countries. And it comprises centers, 100, about a little bit more now, 111 centers from Germany, and 5 from Austria, and 3 from Switzerland. And I'm very honored that one of my senior doctors, Dr. Böttcher, is now in the board of this Fertility network. And to give you also some numbers and insights about this, in total they perform about 1,000 consultations per year. And the webpage of this Fertility network, it provides a lot of information. They have flyers. They provide for female and male cancer patients, but also for young cancer patients who are under the age of 18, and fertility preservation and fertility itself is explained very well. And this webpage is accessed over 150,000 times per year. So now we have on the one side the oncologist who worries about tumor size, stromal invasion, lymphovascular invasion, and resection rate. And on the other side, we have the endocrinologist, which is us, who worries about age, antral follicle count, AMH, the sperm quality, and the possible child wish. And these, it is quite a challenge to get those two different disciplines on one table, and to find a way where everybody is happy, and of course everyone worries about their patients. So now when we talk about the programs of fertility preservation options, we have to have a look what options we can offer to female and male cancer patients. And I will start in this talk with the male cancer patients, because it's a lot easier. When we look at the most common cancer types in male cancer patients, it's mostly testicular cancer, leukemia, lymphoma, and sarcoma patients we counsel. What can we offer? We can offer them cryopreservation of sperm. We have to keep in mind that about 50% of the live cells are lost when we perform this. And this is, I think, a very important information, that about 20% of patients already show azoospermia at the time of cryopreservation, are not able to ejaculate at that time. Then we can also offer cryopreservation of testicular tissue by performing testicular sperm extraction. We call it TESE here, or microsurgical TESE. I performed with my colleagues, or my colleagues and me performed a study in male cancer survivors who underwent sperm cryopreservation, and we included 50 male cancer patients in this study. It was published just this year in the beginning. When we look at the demographic data, the patients were around 25 years old at the time of diagnosis and the time of cryopreservation, and around 30 years when they came to that follow-up visit. And most of the patients had hematological malignancies followed by testicular malignancy. The others comprised patients with mostly sarcoma. And the vast majority, around 84% of these patients, underwent chemotherapy, and the rest underwent radiotherapy. And we assessed the sexual function or possible dysfunction by the International Index of Erectile Function. It is a questionnaire which can be easily filled out. And we also asked the patients to perform another sperm analysis. And what we found is that the erectile dysfunction is prevalent in this group of patients with around 21%. And I think this is quite high, because these are 30-year-old men, and 1 out of 5 suffers from erectile dysfunction. And we also looked and compared about the sperm analysis at time of diagnosis with the sperm analysis of time of follow-up. And we didn't find any difference in concentration, total count, or progressive motility. But we did find that more patients, and that was a significant difference, suffered from pathospermia. So before diagnosed it, it was already high. That was 28%. And again, this is patients who were at that time 25, 26-year-old. And then after time of follow-up, it was almost half of the patients. So I think this is a very important topic which needs to be addressed, is assessing first of all, offering the male patients also to perform another sperm analysis after a certain time after their cancer treatment, but also offer them to talk about erectile dysfunction. So how do we proceed? And that is another picture of slide from the ESMO guideline when we counsel a male patient who is about to receive gonadotoxic treatment. They have to evaluate, and we use this slide or diagram where we look how high the risk is. And we ask them if they want to preserve fertility, and most of the patients do want to. And if they say yes, and they're able to ejaculate, it is easy, the sperm will be cryopreserved. If they're not able, or we do not find sperm in the semen, then we perform tease or micro-teasing. And that is quite easy. In difference to fertility preservation options in women. And here you see how many patients we counseled in the last year. Or the last years, it's about 224 consultations.
Sorry, excuse me, Elizabeth.
Yeah.
Could you please make it a little bit larger, probably? Like the...
Yeah.
Okay.
Better?
Yeah, maybe with the slideshow. Yeah. Yes.
Now?
Okay, thank you.
Yeah?
Yeah, perfect. Thank you.
I like this. So most of the patients had Hodgkin or non-Hodgkin lymphoma and breast cancer, and that is in line with the literature. Now I have to see I can proceed. Now you're seeing my next slide? Yeah, about the fertility preservation.
Yes.
Does it work?
Yes.
So when we look into fertility preservation and options and methods in women, we have bigger variety of bigger options. We can cryopreserve oocytes or embryos. Also, we can perform in vitro maturation of oocytes. We can apply GnRH analogs. We can perform cryopreservation of ovarian tissue, and we can perform transposition of the ovaries. I'm not going to talk about the IVM technique, as it is still an innovative fertility preservation procedure, and it is not performed largely throughout the world, and it is also not performed in Innsbruck. So the most common and most used method is the controlled ovarian stimulation, and here there exist several studies who compare different stimulation programs. And most, of course, in most parts of the world, we use GnRH antagonist protocol because it's safer. And here's a typical stimulation protocol. I'm sure you perform it the same. That we can perform random start because we know we have time limit, and there exist several studies who compared random start protocols to really timed start, so with the first day of menstruation, and there was only a difference in 1 day of time of stimulation, but not a difference in the amount of collected oocytes. And I think this is a very important information to us, fertility protection doctors, and also for the patients, that they do not lose any time. The egg retrieval here in Austria is performed not on a general anesthetic, but in a pseudo-analgesia, so the patients do not feel pain, and afterwards it is fertilized, performing ICSI. So when we look into the German guideline, I will of course translate that side. It's about the oocytes gained, and we see that it is about 12 oocytes when we look at patients, or 13 oocytes when we look at patients between 31 and 35. And the German guideline and also the ESHRE guideline says we should also offer patients who have a partner that they do not fertilize all oocytes, but only part of it. So they will have also oocytes unfertilized. If they split up or the relationship ends, they can use these oocytes. And that is, I think, the best data we have so much on how many oocytes are needed to achieve a live birth by Cobo et al. And we know that 35 seems to be a cutoff. And when a woman collects around 10 to 12 oocytes, which is realistic, as I just showed before, she has a 60% chance of live birth. This is cumulative. While when she's older than 35, this is only around 30%. And she also, Dr. Kobo also compared the live birth rate between patients who underwent oocyte collection because of an oncologic indication to patients who underwent this procedure because of age-related fertility loss. And this is 41% live birth rate in oncologic patients, while it's around almost 70% for patients with age-related fertility loss. Now let's look at a very common patient group. This is breast cancer patients, and we see these patients quite often. Here it is important that when we stimulate those patients, we also use letrozole to keep the estradiol levels as low as possible. And we do also trigger them with GnRH agonists. Is this a safe procedure in breast cancer patients? I think this is the biggest study which has been conducted so far. There's another review we will talk about later, but that original work looked to patients who were around 79 patients who underwent a controlled ovarian stimulation, and they compared it to this group to around 136 patients who underwent no intervention, and they looked into the disease-free survival. And they found no significant difference in relapse-free survival or disease-free survival, which assures us that we can offer patients with hormone receptor positive cancer fertility preservation options such as controlled ovarian stimulation. That is of course, a very important information. So what about cryopreservation of ovarian tissue? It is typically performed by laparoscopy and a general anesthetic. The work afterwards, the ovarian cortex is worked up. We do it 24 hours after the collection, and we apply the slow freezing protocol. When we look at our department and how many cryopreservations of ovarian tissue we have performed, this is in total 230 patients, and we are quite proud that we have the biggest cryopreservation bank, the biggest cryobank of ovarian tissue in Austria. We started back then in 2007, and still a lot of patients also from quite far come to our clinic to perform this. And here it's mostly Hodgkin lymphoma patients followed by breast cancer patients who undergo this procedure. Now let's look at the guideline of ESHRE and what they recommend. And they recommend to offer ovarian tissue cryopreservation in patients undergoing moderate or high-risk gonadotoxic treatment, where the oocyte or embryo cryopreservation is not feasible, or of course if the patient has a preference and rather performs the cryopreservation. And I think a very important statement is also that it should probably not be offered to patients with a very low ovarian reserve, talking about patients with AMH levels below 0.5 or very low antral follicle count below 5. And it is still considered an innovative method for ovarian function and fertility preservation in postpubertal women. The German guideline does not consider it longer as a innovative method. When we perform autotransplantation, and we are also very proud that we have the first pregnancy now in Austria after performing autotransplantation of ovarian tissue into a peritoneal pouch. And I just performed C-section of a very healthy female or baby around 1 month ago. So how do we perform autotransplantation, and who are the best candidates for this procedure? It's, of course, patients with the symptoms of premature ovarian insufficiency, so patients who show amenorrhea or severe oligomenorrhea, and who also show biologic signs for this, so high FSH levels or very low AMH level, reduced ovarian volume, or antral follicle count, close to 0. And here, of course, we have to talk about the risk of metastasis in the ovary before we perform this surgery or this procedure. And I think this is sometimes quite difficult, because good candidates to perform are patients who can and do not have the time for controlled ovarian stimulation, so patients with leukemia or Hodgkin's lymphoma. But then at the same time, leukemia patients have a higher risk of ovarian metastasis. So this is quite a struggle how we should counsel these patients. Worldwide, there are around over 200 healthy babies already born after autotransplantation. And here I brought a study from Fertility Sterility of 2020, who looks into the success rate of ovarian tissue autotransplantation. It was a multi-center retrospective study between 2004 and 2018. And I think this is quite interesting, because in total, over 1,300 patients underwent ovarian tissue cryopreservation, and 70 patients came back to undergo 87 ovarian tissue transplantation. This is the data from 3 big centers, and they all performed orthotopic implantation, and 94% return to menstrual cycle, 50 pregnancies were achieved, and 44 deliveries were attained. And the questions remaining about ovarian tissue autotransplantation is which patients should we select? There is the age and the chemotherapy exposure, which plays a role. How should we handle the harvested tissue in the lab? Pregnant dimensions, freezing protocols, and what about the transplantation technique itself, the transplantation site, surgical strategy, and risk of metastasis. And there are, and I think now it's unfortunately this does not work when we cannot use this full screen. But I just wanted to point out here that there exist several ovarian tissue autotransplantation techniques into the pelvic wall, into the ovary, or onto the ovary. And as it just came from ESHRE this year in Milano, there was a very good study, which is not published yet, but they compared the different techniques, and they had quite a big sample size, and they could not show any difference regarding pregnancy rates or number of retrieved eggs in the different groups. We in Austria, or not in Austria, but in Innsbruck, typically perform the autotransplantation into the pelvic wall, where we first make a small incision and then we have a pouch. And I think it really relies on the surgeon, so that he or she chooses the technique he thinks can perform best. And that is another story which is published very recent and was presented at the ESHRE as well, about the risk of residual disease in ovarian tissue of leukemia patients. And as I pointed out just before, this is a very sensitive group of patients. And what they did is they assessed the minimal residual disease in 15 leukemia patients. And it was positive in 5 out of 15 patients. So 10 patients could undergo the autotransplantation. And what they also performed in that study is xenografts into immune deficient mice with the tissue from 10 leukemia patients. And they did not find evidence of leukemia cells after the 6 months grafting period. So I think this is very interesting, and it is a very innovative and new study that we can also offer these patients who have maybe stored the tissue quite a couple of years ago, still the opportunity of ovarian tissue autotransplantation. Shortly also about GnRH analogs, it works about the suppression of ovarian function and leaves a reduced vulnerability to the ovary. It can make hot flashes and osteoporosis if you apply it more than 6 months. And we usually offer also add-back therapy. What does ESHRE say about it? Should GnRH agonists be applied to patients? Well, it should be applied as an option for ovarian function protection in premenopausal breast cancer patients receiving chemotherapy. However, limited evidence exists on the protective effects on the ovarian reserve. It should not be offered as the only treatment option, but as an add-on. And I think this is very important. And also in other malignancies than breast cancer, should not be routinely offered as an option for ovarian function protection. I just had a phone call yesterday of a patient with a sarcoma, and they had to start the chemotherapy today because she is a very aggressive tumor. And of course, I told them at least we can offer GnRH agonists because we do not have time for any other fertility protection or preservation options. But of course, this is not ideal. Transposition of the ovaries, well, we do perform this here in Austria, but or also in FertiProtect network. I'm working on a study about this right now, but it's very rarely used in common. The aim is to reduce, of course, the ovarian damage due to radiation. The risks are generally low. There describes ovarian cysts sometimes, and the ovarian metastasis at the site of port incision is quite low, underneath 1%. Success rates seem to be quite high, but they differ very widely. The problem is that the radiation damage not only applies, of course, to the ovaries, and they can be this damage can be reduced by transposition of the ovaries out of the site, but we still have the damage to the uterus, and that sometimes makes pregnancy just unable. Let's look at a timetable when we want to offer all fertility preservation options to a patient, and then it's typically like this: that we first perform laparoscopy, and then after 2 days we start the ovarian stimulation. It takes around 12 days in average, and then 2 days after we perform the follicle or egg retrieval, and 2 days after the egg retrieval we typically patients can start with chemotherapy. So in total, even if we do offer all or perform all fertility preservation options, we only lose 2 weeks of treatment start. Now, when we look into the world and the trends in patients' choice of fertility options, there's also quite a recent work from 2019 performed in Sweden. It is a prospective study which was performed between 1998 and 2008, and in total 1,000 and a little more adults and around 200 girls receiving fertility preservation counseling were included. The mean age at time of fertility preservation was 27. The mean age at time of follow-up 34, and the mean follow-up time was 6 years. So let's have a closer look at patients' characteristics. When we look at the adult woman, around 300 patients, not 1/3, 1/4, opted for no fertility preservation option because half of them said, well, I don't want to, and the other half, it was not recommended. And around 800 patients underwent fertility preservation options, and it is divided into patients which were single at that time point, around 400, versus those patients who had a partner. And I think, first of all, it's very important to see that only 19 or 14 cycles were cancelled. And when we look at the single woman, half or 1/3 underwent ovarian tissue cryopreservation, where the other half or 2/3 underwent oocyte cryopreservation. And when we look into the married and not married, but patients with a partner, there, of course, we had a larger number of embryo cryopreservation. And then when we look at the 178 children and teenagers between 1 and 17, we have around 114 patients who undergo ovarian tissue cryopreservation and 24 patients with oocyte cryopreservation. Now, let's look at the trends in the patient choice of fertility options. Well, in children and adolescents, it is seen that there's an increasing number of girls who elected to undergo controlled ovarian stimulation and transvaginal oocyte retrieval in recent years. You see this increase here. This is, of course, post-menarchal girls. And when you look into adults with and with partner, the controlled ovarian stimulation and pickup of oocytes has replaced the controlled ovarian stimulation and freezing of embryos as the most popular fertility preservation method among these patients with partners. So, as you can see, there is a change. More young women underneath the age of 18 also opt for the controlled ovarian stimulation, and more women also with a partner want to freeze only their oocytes and not embryos. Now, how many women return for fertility treatment? And I think this is a very interesting and important topic. And this was also addressed in the same study and also by another study by Druckenmüller et al. And when they look at the potential number of patients who can return, well, it was 563 patients in total, and 28% returned for counseling and 12.6% returned for fertility treatment. And those with childhood cancer, even more returned for counseling, but less returned for fertility treatment. And also in the study by Druckenmüller, the numbers were not as high. Here, 10 out of 176 patients with a mean age of 31 returned to attempt pregnancy. But we have in total, I would say, which is very interesting, almost 1/3 returns for counseling. Now, how are success rates for fertility treatment after fertility preservation? The study by Druckenmüller et al. They looked into the success rates of patients who cryopreserved oocytes. They thought 11 cycles, they had 11 thought cycles, and 9 resulted in embryos suitable for transfer. The implantation rate was as high as 27%, and the live birth rate was as high as 44% per embryo transfer. And in the study by Rodriguez et al. And Wallberg et al., 75 patients with malignant indication returned, and 22 patients opted for the use of the thawed oocytes or embryos, and 4 patients used oocytes from retransplanted tissue. And they have had live birth rate of 34% of patients with benign indication and 66% with malignant. So really, the other way around, 34 for malignant and 66 for benign indication, which is really high, I would say. So now back to our case. Again, it was the 30-year-old patient, no children, but living in a relationship, receiving this therapy. And of course, as I just said, we first look at the risk of permanent amenorrhea, and with this applied treatment, she falls in the risk of intermediate, in the group of intermediate risk. So we counseled her about the fertility preservation options, and she here's a flow chart of the ESMO guideline from 2021. How should we counsel these patients? If they have the desire to preserve fertility and we have less than 2 weeks, we should perform ovarian tissue cryopreservation, preferable at ages lower than 36. This would be an option for her. If you have more time, and typically we do have that time in breast cancer patients, we should also opt for ovarian stimulation followed by oocyte or embryo cryopreservation. If she only has the desire to preserve ovarian function but not preserve fertility, we can opt for GnRH agonist during chemotherapy. So this patient opted for controlled ovarian stimulation. 25 oocytes were retrieved and half of them were fertilized. During chemotherapy, she also used GnRH agonists. So what do we do when this patient comes back to achieve pregnancy? There also exists some recommendation in breast cancer patients, and this is that they should complete or perform at least 18 to 36 months the endocrine therapy. In that case, it was tamoxifen. Then they stop the endocrine therapy. We have a washout period of 2 to 3 months, so the patient should not get pregnant. She should use contraception. Then we have a window of 2 years where she can achieve pregnancy. And then she should, after delivery, she should restart for endocrine therapy and complete this of a total to 5 to 10 years, depending on the type of cancer she had. We, of course, have also to talk about the safety of pregnancy in women with breast cancer. There's a very big review published by the Italian group, followed by Alambertini, and they compared the probability of pregnancy and also disease-free survival or general survival in breast cancer patients with the general population, with a very large number, so 8 million women without any cancer or of the general population, compared to 112,000 patients with breast cancer, of whom 7,000 got pregnant after diagnosis. And there is the first very important information that patients with breast cancer have a 60% less probability of pregnancy. And I think the very important information, which is also important to tell the patients while fertility preservation counseling, that there is no difference in disease-free survival. Well, they do have a better overall survival in breast cancer patients who were pregnant compared to those who were not pregnant. But of course, and this was also discussed this year again at ESHRE, we would not counsel a patient who had breast cancer in life to get pregnant. But it is, of course, important information that we can really ensure the patient with breast cancer. You do not have to be afraid. You can get pregnant. This has no disadvantage on your disease. This slide shows also the impact on pregnancy outcomes, and we see that patients with breast cancer have a higher, or they do not have any risk in pregnancy outcomes, completed pregnancy rates, spontaneous abortion, induced abortion, but fetal outcomes differ. They have a lower birth rate, and higher risk for preterm birth, small for gestational age. So I think this is just very important when we hand on a pregnant patient who had breast cancer in the past to the obstetricians, that I have a closer look on these patients. So now, in the end, I want to have a look again into fertility preservation options through the world or here in Europe. And that is a very nice picture from the ESHRE guideline. here on the left, you will see what is allowed for fertility preservation options in different European countries, and also which is funded. And you can see that in most of the countries, also cryopreservation is allowed, but only in around half, or not even half, 1/3, the costs are covered. So, and then we have some countries in Europe where embryo cryopreservation is, most of them is allowed, but not in Italy and in Portugal. And again, in ovarian tissue, cryopreservation is allowed in most of the countries. So this applies for patients who undergo fertility preservation because of cancer. The cost coverage is higher for ovarian tissue cryopreservation than for oocyte or embryo cryopreservation. And I'm also curious how you perform or proceed this in Indonesia. And then here on the right side, you see the same options for patients who undergo fertility preservation due to benign disease. And here it is mostly the same, only that in some countries in Europe it is not allowed to perform anything because of benign diseases such as the Czech Republic. And again, in Italy and in Portugal, embryo cryopreservation is not allowed. So let me summarize. Fertility preservation options should be offered to all patients, and the risk of gonadotoxicity should be assessed also in all patients. And that is really very important, that the patients get the chance to choose between performing fertility preservation or not. And the counseling should be dependent on the available time in malignancy. Most data we have on embryo cryopreservation, and our ovarian stimulation is a safe option in breast cancer patient when we also administer letrozole. And the return rates for fertility treatment is up to 27%, also indicating that it is a good thing or a good option we offer these patients, that quite a lot of patients also return, and live birth rates are between 34 and 44%, so quite high. And as this is also part of my research, the general health and sexual dysfunction, I can only advise to include also the screening for sexual functioning in the follow-up. Thank you very much for your attention. I hope I was in time, but I think I did. This is a flyer of our clinic. With this slide, I want to end my talk. And we hand this slide to all the patients we counsel. And they all have also information on the person who counsels them. So this is Dr. Böttcher and me, Dr. Reiser. And I think this is very important when you build up a fertility program, that you have always the same doctors performing it. And these patients like to come back to clinic and to visit. Thank you very much.
Thank you very much, Elizabeth. And for the audience, let's give virtual applause for Elizabeth. Yeah, thank you very much. Vielen Dank für Ihre It's been a while not talking German. Yeah.
It sounds very good.
Yeah. Not really, actually, but congratulations. I heard you have live birth 1 month ago. Is it from the ovarian tissue preservation or from all sides?
No, it was autotransplantation of the tissue, and she got pregnant spontaneously.
Spontaneously. Sorry, Elizabeth, I cannot hear your voice.
Someone
Yes.
muted me. Now again. Yes, she got pregnant spontaneously. She did not undergo afterwards.
Okay.
Yeah.
So actually,
how do you perform it in Indonesia?
It's still it's still in experimental at the moment. So as we can see that you have started from 2007, so until now it's been 15 years. But actually, we just started at around 2017. We started to raise the awareness of the oncologists and also from all health care givers. So at the moment we started from the experimental projects for this, and also we still try to raise the awareness not only for the clinical settings but also for the education as well. Yeah. So
is it legal to perform all of this? So oocyte stimulation, oocyte embryos, is it all possible?
Okay, so at the moment we haven't started yet in the clinical settings. So at the moment we started only in the experimental settings. But actually we have several patients already started to approach us, or maybe later Dr. Widat also can tell us how it is going at the moment in the clinical settings, Dr. Widat.
Yeah, thank you. I think it's very early to integrating fertility preservation services into IVF clinics. Yeah, and until now, okay, we have maybe 2 or 3 patients ovarian tissue cryopreservation, but not yet to retransplant. Unfortunately, one of them dying from due to ovarian cancer. Yeah. Okay. And we don't have experience until now to retransplant autograft and autotransplantation to the patient.
Yeah. Actually, Elizabeth, how many live births at the moment from ovarian tissue preservation or from oocyte preservation in Innsbruck?
So from autotransplantation of ovarian tissue, we have 2 patients in total.
2 patients.
2 patients. About using the cryopreserved oocytes or embryos, we have a lot more. We have around 30 patients.
30 patients already with live births.
With live birth or ongoing pregnancy at the moment.
Okay.
But, yeah.
Okay. Yeah. We have several questions from the audience here in the chat box. Maybe I will start from the first one. This question is for Dr. Widat. From Ariana Meilinawati. Dr. Widat, thank you for your presentation. I'd like to know what did you use for preventing the microbial infection of CAM in this research? Congrats for finishing your research.
Yeah, thank you, Dr. Ariana, asking me for a question. Maybe we provide some effort to prevent bacterial contamination on chorioallantoic membrane. First, we have to try to make an egg incubator always clean before and during egg incubation, and maybe swipe the internal surface of incubator. Maybe we can swipe with alcohol is maybe possible. Second, ensure the egg surface clean before incubation, before we enter to the incubator. And third, maybe please ensure that we use the sterile equipment and sterile instrument to make a window on eggs. And the last, okay, we don't need antibiotics on CAM to prevent the bacterial contamination. Yeah. Yeah. So in brief, maybe general precaution only. Yeah.
Yeah. So regarding on the CAM, we don't need the antibiotics, but we also added some antibiotics in the transport medium. This is added by Dr. Agung as well. Yeah, thank you, Dr. Widat. And there is also another question for Dr. Wida. This is from Dr. Ita Fauzia. Smaller size of ovarian tissue will give better results. Small means thinner, or it is related with thin specimen.
Small. Yeah, thank you, Dr. Ita Fauzia. I mean, small is about dimension, length, and width. We have similar thickness, 0.1 centimeters, but we divided the size by two size. For length 0.4 and the another size 0.8 in dimension, length and width, but similar thickness, 0.1 centimeters.
Okay. How about in Austria, Elizabeth? How big is the size of the ovarian tissue transplant?
Okay, so when we perform the laparoscopy, we typically have half of an ovary explanted. We use half an ovary. Sometimes we use on both sides 1/3 each. And then we cut into 2 millimeter pieces and we freeze those. And when we perform the autotransplantation, we use for the pouch around 5 to 6 of these pieces. So we have the option, if you have half an ovary, that gives more than around, I think, 18 pieces, 12 to 18 pieces, we have the possibility of several attempts.
Okay, yeah. So it's a really small. So it's smaller than Dr. Widat's size. It's 4 millimeters. Yeah. And the thickness is also the same, like 1 millimeter. Okay.
Yeah. The thickness is given by the size of the or the thickness of the cortex.
Yeah. Do you have any advice to overcome difficulties to provide these small or thin specimens? Because, like, for example, in our research, we have 4 millimeters. It's also quite challenging to make this really small and not to lose so many tissue at the time of the preparation. How about in your settings?
Well, we use for the preparation, we use this, how to say that in English, when patients who have breast cancer and they have the diagnosis, they have this punch.
Like a punch biopsy?
Yes, and we use this typically to perform the punches, and then we don't have that much rest tissue.
Okay. Yeah. And also for
we can arrange the talk or the contact with our lab or research, not doing research, with our fertility lab to maybe overcome these problems.
Okay.
Maybe I would like to ask Dr. Elizabeth, what device you use for vitrification? Closed device or open device?
Close.
Close. Okay, for storage. Okay. Yeah, because it's very difficult to use open device to store the very small size.
Yeah.
But until now, Innisbrook is still using the slow freezing machine?
Exactly.
Okay.
Okay.
Yeah, because we don't have such machine, so we started to develop the vitrification procedures.
Yeah, but we are very used to proceed with this, so the embryologist, the biologist likes to stay with that procedure. Yeah.
But have you tried to vitrify? No,
not so far. No.
Not okay. No. Okay. And for Dr. Widat, Dr. Ita also asked, do you prefer the MSO or propanediol as a cryoprotectant agents?
Yeah, I think many study about what kind optimal CPA, the cryoprotectant agent. And I think ethylene glycol maybe provide a better outcome than DMSO in ovarian tissue cryopreservation. Maybe Dr. Elizabeth have answer about that. Which better DMSO and ethylene glycol or others for CPA?
Sorry, we cannot hear your voice.
And use DMS.
DMSO.
Yeah.
Okay. Because this is for slow freezing machine.
Exactly.
Okay. Yeah. We have other questions from Dr. Ita Fauzia. For Dr. Elizabeth, thank you for your presentation. Based on your wide experiences, please advise how to optimally delivering whole and detailed information to the patient, since fertility preservation is a very complex procedure. So it's regarding to deliver the information. And how is the situation, especially in the patients, to understand about the ethical issue rise from the FP program?
Well, that is a very good question, since the patient comes in for counseling and we have all of a sudden she needs to decide about fertility preservation options, and she never heard about these options before. So what we typically do, we do on the first day, it takes around 1 hour, 1.5 hours. We talk about all the options, and we have these flyers we give the patients where there's a small summary of each procedure in easy words. And then we meet the next day again. And they had that one night or one day to talk about it with their friends or relatives or whatsoever. And then they come back the next day. Some of them wrote questions, and then they understand better what to do. I think this is really providing some material such as flyers with a short summary of each procedure is very helpful. And when it's about the second question about ethical issues that rise, I think you might mean that patients store embryos and oocytes for a long time, and then they will not need it, as fertility preservation is only an insurance, and quite a lot of patients get pregnant spontaneously afterwards. Well, I do not see that many patients who have big problems about or do rise concern about this, about the ethics, especially because we have only little time to decide. So I think maybe this is also a question about religious groups, but I do not see that much problem about this. What we offer sometimes is, and I think this is a good option, is then when patients come back and say, well, I have all these embryos stored and I don't want to use them, we give them back to the patient, but not in the luteal phase, so in the beginning of her cycle. So we transfer embryos, and yeah, that is a procedure which helps some patients. Yeah.
Okay, thank you. Maybe Dr. Widat will add some answers.
Yeah, I think it's depend on the patient. Yeah, if the patient have a husband, yeah, I think the best choice is embryo cryopreservation, not ovarian tissue cryopreservation. But okay, if the patient maybe prepubertal girl, or maybe the chemotherapy have to give immediately, maybe the option is ovarian tissue cryopreservation. But I think the prognosis for us maybe embryo cryopreservation better than more difficult ovarian tissue cryopreservation. if possible, of course.
Okay, thank you, Dr. Widat. And we have another question here from Dr. Batara Sirait to Dr. Widat and Dr. Elizabeth. How many stored eggs is considered to be enough for fertility preservation, considering we often don't have enough time to do more than one stimulation cycle?
Yeah.
Yeah, maybe you start. Go ahead.
Yeah, okay. I think maybe it depends on how established our ability to control our prognosis of survival oocyte preservation. Maybe it's depend on every laboratory individually. But maybe in one journal, the appropriate amount of oocyte to store is 20, because the viability or survival of oocyte less than embryo survival. So we have to provide more amount of oocyte to provide enough prognosis life birth. Thank you.
Yeah, please.
Yeah, as I showed the data from Kobo, we can see live birth rates around 50 to 60% when women store 10 to 12 oocytes when they were younger than 35, increasing to 80% cumulative rise birth rates when they stored 18 to 20. So I think yes. I think it's not good to get more oocytes, and then we have an overstimulation situation where we have to postpone the therapy. But between 10 and 20 is a good amount. Yeah.
Yeah, thank you. So it's between 18 to 20 oocytes. And maybe I invite the audience to ask directly using the raise hand features. Is there any already? No, maybe I will read one more question from the chat box from Dr. Ayulu Ratri. Thank you for the great lecture. I would like to know about the patient who have already received gonadotoxic treatment. I think it's already started, or a previous course of chemotherapy. Is it still possible the patient can be offered with OTC as an option of fertility preservation?
If I might answer this question, so in general, we do not perform ovarian tissue cryopreservation once the chemotherapy has started, because the results do not seem to be very good. And we also have to think about the type of patients who are this. And for example, if it's patients with Hodgkin lymphoma who have a big tumoral mass in their mediastinium, and so the therapy has to be started right away. We do not want to perform surgery because they have very high risks of complication due to the surgery itself and anesthetic itself. And there exist small studies where they compare the oocyte retrieval between patients before and after the start of already a cycle of gonadotoxic treatment. And the results are also not good, but so yeah, we do not, I think it is not recommended, and we do not perform it.
Okay, how about the other type of fertility preservation option, not the OTC? For example,
well, once the chemotherapy is started, we also do not perform oocyte stimulation, but we wait after they really finish their therapy when they have a disease-free survival of, let's see, 6 months, and they can come and still perform that. But of course, this is in general not ideal. Yeah.
Okay, thank you. And from Dr. Widat, maybe is there any more to add?
Yeah, I think it's also we have to consider what kind of chemotherapy agent doctor give, because maybe chemotherapy can divide it into high risk, medium risk, and low risk of gonadotoxic effect. If patient receive a low risk of gonadotoxic effect, maybe we can consider, but maybe we check again about ovarian reserve.
So it depends on what chemotherapeutic agents they use, doctor, and also the ovarian reserve of the patients. Okay.
Yeah.
Is there any more questions from the audience? Maybe from the raise hand feature to ask directly to the speaker. If not, maybe I have a lot of questions, but I will ask the audience first. Okay. Dr. Ita Fauzia, please.
Thank you, Dr. Sarah. Actually, I'm waiting for other question for the audience. Okay. Thank you very much, Dr. Widat. Dr. Elizabeth is such a very enlightened. Start my video. Wait. Okay. I'm in the lab working for Dr. Widat. Thank you, Dr. Elizabeth. It is very interesting that you are mentioning about 10 to 15 oocytes to be preserved or to be collected from the ovarian preservation. So actually, I'm quite curious how we trying to adjust this number of oocytes we collected from the specimen. And yes, Dr. Widat mentioning about 3-4 patients we have been preserving from the vitrification, not slow cooling. I think it's a challenging situation with the vitrification because still I am thinking about reculturing or grafting. Please advise us, Dr. Elizabeth, about the number of oocytes and reculture or grafting for this situation now after the hoeing the specimen. Thank you, Dr. Sarah.
Thank you, Dr. Ita. So it's about how to perform the simulation so that we have 10 until 15 oocytes. And the second one regarding the regrafting, the retransplantation about the ovarian tissue.
About the aim of 10 to 15 oocytes, we adjust the stimulation protocol and the administered gonadotropins by knowing the AMH level and the antral follicle count. And then we decide which protocol we use. And so the woman does not result in overstimulation. So she has 10 to 15 oocytes. So this is, I think, determined by the dosage of gonadotropins when we stimulate the woman. I hope I answered that. I got the question right. And when we do the transplantation of the tissue, I didn't get quite the question. What was the question? Sorry again.
I mean, if we culture the ovarian tissue, will it be, more beneficial to do compared to we are doing the grafting? Do you have any
suggestion? So the culturing the tissue instead of the transplantation directly.
Yes, we wait 24 hours. It is cultured 24 hours in DMSO until we refreeze. So we wait 24 hours before we do this. And
so all patients will be grafted, not culturing in the culture situation till we have mature oocyte.
No, that when we culture ovarian tissue, we retransplant the tissue and then the woman gets pregnant spontaneously or she's stimulated. But we do not culture oocytes from. Sorry, now I think I got it. We do not culture oocytes from the tissue. No, this in vitro maturation. No, we do not perform.
Yeah, not in vitro maturation. Yeah.
No.
Okay, thank
sorry,
you.
Now I got it.
Yeah.
Okay. So I think in Innsbruck, you also have done like if you took the ovarian tissue from the patient from laparoscopy, and then you also try to find the oocytes afterwards before you freeze it, if I'm not mistaken.
Yes, because I think you performed that very well. I heard.
yeah. But how about now?
We still perform from the tissue, which cannot be used, so the very small pieces. Neutral red, we perform neutral red staining to see to stain the viable oocytes, or to see the oocytes. But that is a very only for research.
Okay,
yes,
so it's only for research.
Yes.
Okay.
And since you left, we do not do that anymore. So you have to come back. I hope your boss does not hear this.
Yeah, I'd love to. Okay, maybe Dr. Widat would like to add some more information.
Yeah, I think Dr. Elizabeth lecture very enlightening for us with Innsbruck Medical University experience. I think we have learning about your lecture. Yeah.
And about how to adjust the 210 and 15 oocytes, Dr. Widat, maybe you have experience about that as well?
210 oocyte. I think the challenge of oocyte cryopreservation is like I said before, the probability of survive less than embryo survival after cryopreservation. So this is very challenging, but maybe in the future, if we have more better protocol, I think this is a very opportunity for us. Depends on successful to adopt or to find a better protocol.
Yeah. Okay. Thank you, Dr. Widat. And maybe another question, Dr. Batara Sirait, please.
Yes, thank you, Dr. Sarah. I would address my question to both speakers, Dr. Widat and Dr. Elizabeth. How about your experience in doing the duo-stim, the both phase stimulation? Because we most of the time we don't have enough time because of the oncologists want to get the chemo in and or the radiotherapy to a certain type of cancer in the reproductive age patient. I used to use the dual stimulation to get more oocyte to preserve. Thank you so much.
Thank you.
So if I might answer that question. So if we do not have enough time to perform dual stimulation, we are afraid that the patient does not have enough oocytes. Knowing this from her AMH11 and her antral follicle count, we rather counsel the patient that she first undergoes cryopreservation of ovarian tissue and then one round of stimulation for retrieval of oocytes. We basically never perform dual stimulation because of the same issues or problems you just raised, that we do not, or oncologists will not give us 4 weeks until the therapy starts. So I think when you have the feeling you rather feeling that you will not gain enough oocyte would be perfect or ideal to really do cryopreservation of ovarian tissue first. But as I just figured out, this is still experimental and in the right part of your country. Yeah.
Yeah. And also, I think the cryopreservation of ovarian tissue has more criteria to perform it. So, what do you think? So, if you say that if the oocyte stimulation or oocyte cryopreservation is not eligible because the time is so short, you can approach the patient to undergo cryopreservation of ovarian tissue. But however, not all the patient is actually feasible for these procedures. Can you also have you done like Dr. Batara said, this dual stimulation?
We have undergone performed it, but maybe 2 times in all of the patients we've counseled so far, because we have mostly the chance of performing both cryopreservation of ovarian tissue and then the stimulation. But we are very lucky, of course, to offer both these options. So yeah, but I know from the literature that it works quite well to perform both, and so that is also a safe procedure for the patients, because I think it does not make quite a big difference. If you already have time for 2 weeks stimulation, you also have time for 4 weeks stimulation, because it's either the patients who have no time at all, who have to really go into their chemotherapy right away, or it's the ones Hodgkin lymphoma patients or breast cancer patients who have more time. So I think here maybe the answer really lies in to improve the communications with the oncologist to ensure that we already also have time for 4 weeks if you have time for 2 weeks.
Yeah, thank you. Dr. Widat?
Yeah.
Sorry.
Okay,
Can I add some more, moderator?
Yes, please, doctor.
Sorry. So if you prefer to do the tissue cryopreservation, do you freeze the immature oocyte, or you choose to do the in vitro maturation, and then you choose to freeze the mature ones? Thank you.
We do not perform the freezing of the oocytes of the gained tissue, but we freeze the whole tissue. The tissue cut into small pieces of 2 to 3 millimeters. They are freezed by slow freezing protocol, and then the tissue itself is auto-transplanted later to the ovary or to the peritoneum, but we do not extract oocytes from the gained tissue, because this is still experimental and we do not perform this. In general, when we look into this vertical tech network, so all of these centers, there is only below 5 who do this in Austria, Germany, and in Switzerland, to really store the oocytes from the gained tissue. But this is only in allowed or possible in research setting. And I think this is really a harder step to establish than to rather first establish cryopreservation of ovarian tissue and autotransplantation this tissue to the patient, because this is generally in the world more established.
Yeah. So
thank you, Elizabeth.
Yeah, in Innsbruck, you don't do it anymore. It's just in experimental, right? Okay, Dr. Widat?
Yes. Okay. I think we can also offer the patient for random starting stimulation instead of conventional starting stimulation. In conventional, we start to stimulate in the day 2 or day 3. So if the patient comes to us for stimulation in day 10 or then day 11, maybe we have to wait for until next cycle. But in the random stimulation, we can starting in every day of the cycle to stimulate. And the result of the study, I think, is comparable random start stimulation with conventional start stimulation. This maybe can shorten the window of before chemotherapy. Thank you.
Thank you, Dr. Widat. I think we have another question from the chat box. I think this is also one of the issue that I would like to ask actually. So this is from Dimas Wahyu, the student for 4th semester. Good afternoon. I would like to ask about the effect of malignancies for ovarian tissue vitrification. I think it is about the reimplantation of malignant cells in ovarian tissue vitrification or ovarian tissue transplantation afterwards. How about the experience in Austria regarding this? What you do is just to differentiate the type of the malignancy, and then you just store it and then transplant it based on the malignancy. And there is other type of malignancy that it's really prohibited to do the vitrification, or you have other type of methods to not reintroducing the malignant cells.
Yeah, that is a very important question. So what the 2 autotransplantations of ovarian tissue we performed so far were in patients with breast cancer with a very, very low risk of ovarian metastasis. When we counsel patients with higher risk of ovarian metastasis, so patients with leukemia, for example, we generally advise them to rather perform the stimulation and egg retrieval than to perform cryopreservation of ovarian tissue. Although we have sometimes not the time for this, we counsel them, like telling them we can perform ovarian tissue cryopreservation, but at the moment in Innsbruck we are not able to give them back their tissue as autotransplantation. But when the patients are very young, meaning 20, 25, we can only hope until they raise their child wish that research is already better, and we can offer them to give back the tissue before it's tested for metastasis. And I think I pointed out or showed the data of that one very small study from Israel where they looked into the metastasis in patients with leukemia, and they found metastasis in 5 out of 15 pieces. But on the other hand, it was 10 out of 15 patients who could receive their tissue to be able to go undergo autotransplantation, although they had a malignant disease with a very high risk of metastasis. So I think you can counsel the patient. It is possible, but the return and the autotransplantation of this tissue so far is only performed in very little centers in the world, and they have to keep in mind that maybe we just undergo the surgery and they cannot use the tissue afterwards.
Okay, so until now it's only for breast cancer in Innsbruck, or also
no, also for
lymphoma?
other patients.
Okay.
In lymphoma also, but not for leukemia patients, for example. Yeah.
Yeah. So no hematological cancer.
Yeah. Yeah.
Okay. How about the gynecological cancer? Is it still not recommended
It
at
is
all?
also possible for cervical cancer, and of course for ovarian cancer. We have to be honest. This is not patients who undergo fertility protection, because mostly the disease is so advanced that they have not a very good 5-year survival rate, and there are no candidates for fertility preservation. Yeah.
Okay. Thank you. And Dr. Widat, maybe you have some more information to be added?
Thank you.
Okay, maybe Another questions from the audience? Is there any audience who want to ask? Maybe using the feature of raise hand? Not yet. Okay. So maybe I will ask Elizabeth another question. Do you have experience on preserving the fertility from non-cancer patients, such as in genetic predisposition like in Turner or in endometriosis patients? Because we have quite a lot of patients with those backgrounds.
Well, this is something we just started to establish and to be also in the mind of patients and doctors. But especially in patients with endometrioma, we started this already a couple of years ago, because these patients also come and see us because they are infertile, and then we diagnose the big endometriomas. And depending on the size, we first perform the egg retrieval, and then we perform surgery, yes, and then they have embryos frozen. Also for genetic predispositions such as fragile X or Turner syndrome, but there we have the problem often that, of course, the ovarian reserve is already almost zero when the patients are very young. But they are here in our center, and we counsel them, yes. And yeah, social freezing is not allowed in Austria, so we do not perform this in our center. No.
Yeah, so it's not allowed in Austria yet for social freezing.
No, it started to be allowed, but we have to send the patients to Germany who are interested in doing so.
Okay. Maybe Dr. Widat have information regarding, we have a lot of patients, I think, with endometrioma, maybe like the large ones with a very young age. And in Austria, it's already common to freeze the oocytes before, for example, the surgery for those patients.
Yeah, thank you, Dr. Sarah. Because we don't have experience until now about ovarian tissue cryopreservation in big endometrioma in young patients. We offer the patient to oocyte cryopreservation until now. If the patient have not been married, yeah. As we know that endometrioma, ovarian endometrioma or endometriosis start growing after puberty. So I think if postpubertal women, young women, they can offer the oocyte preservation after ovarian stimulation. Yeah. Inside of ovarian tissue cryopreservation. Thank you.
Yeah. Yeah, thank you, Dr. Widat. So it's similar to Dr. Elizabeth already said. Okay, maybe I invite again from the audience. I have one question from, not here in the chat box, but this is another question. When is the best time to do ovarian tissue preservation in pediatric patients with cancer? So can ovarian tissue preservation be performed in pediatric patients who have not experienced the menars? Maybe Elizabeth can answer that.
It can be performed, but it's also regarded experimental. We do not perform it in Innsbruck. But there are some centers who do it, but then afterwards it's still experimental. You have to perform the in vitro matrification. There exist some studies, I think, from a big group from Belgium, because they performed it there more often, that they achieved live birth after that. But I can not comment more on that because we do not.
Okay. Yeah. Thank you. Is there any questions from the audience? Okay, from Dr. Widat, maybe is there any question for Dr. Elizabeth?
Yeah, Dr. Elizabeth. I think it's challenging to start fertility ovarian tissue cryopreservation services. Maybe about, do you have experience how maybe do you have a suggestion for us what to prepare before we starting ovarian tissue cryopreservation services in our hospital?
Well, I'm very happy because when I arrived here at the clinic, it was already all set up, as they started in 2007, and I was still in school back then. So I think when you need tips regarding for the technique of storage, freezing, and also warming the tissue or the oocytes, we should get in touch with our embryologists who are quite more familiar with that. And some of them are still here who really started to establish the whole background of this method.
Okay, so what do you think is the biggest challenge on starting the program, especially for us?
Yeah, I think, well, the biggest program is really to establish the work in the lab, because performing the surgery itself is easy. It's an easy laparoscopy, but to really have the tissue stored safely and the procedure of freezing is surely the most challenging part, and also the warming. When you perform autotransplantation, there should be not a lot of time between warming and really transplantation. So these are for sure the issues who are the biggest.
Okay, so it's regarding the laboratory and the settings of the laboratory itself.
Yes.
Okay, thank you very much. Dr. Widat, is there any more questions? Okay, I think there's no more questions as well from the audience. Oh,
we had a lot of questions. It's very nice that there is so much
one more
interest. Yeah.
Yeah, this is from Dr. Agung Dewanto. Dear Elizabeth, if the owner, the patient, died because of the cancer, what will you do with her oocytes or the ovarian tissue? Is it to donate?
No, this is forbidden by law, restricted by law. You cannot donate oocytes or embryos or tissue of a dead person to another person. We use them, part of them, for research, because we ask the patients at time of diagnosis and at time of preservation if they are fine with using the tissue for research if it's not longer needed. But this is only research in that's my research I'm doing in ovarian tissue. About oocytes and embryos, it's basically not impossible. It's very hard to get ethical approval for research. So we cannot donate those oocytes or embryos or tissue to another woman.
Okay, so not to donate for other patients, but to research only.
Yeah.
Right? Okay, thank you. So it is already cleared in the beginning before the patient started the program.
Exactly.
Okay. Yeah. Thank you for your information. Is there any more questions for Elizabeth and Dr. Widat? Maybe I ask once again from the audience here. I think we had more than 100 audiences today. Yeah. Okay. Yeah, I think there's no more questions. Well, I think it's a really nice conversation, and maybe we should talk about our later project between us after this. But thank you very much, Dr. Widat and Dr. Elizabeth Reiser, for really valuable discussion, valuable materials to share with us. And maybe Elizabeth, you have one more take-home message for us before we close the session.
Well, I want to thank you first of all for the opportunity to talk. It was very interesting, and also to hear how you perform it at your center. And I think as a clinician, my message would be that it is most important to really advise these patients, or to tell them the possibilities of fertility preservation, to really to raise the awareness for this topic.
Okay, and one more take-home message from Dr. Widat. Sorry, doctor, the voice is still muted.
Yeah, thank you, Dr. Sarah. Yeah, I think it is a valuable connection between Gajah Mada, Universitas Gajah Mada, and Innsbruck Medical University. And I hope this cooperation, this connection can be sustainable in the future for the research, for the medical services in fertility preservation, and so on and so on. Yeah, I think it's not only the first and the last, but this only a beginning.
Yeah, hopefully we can, this is the beginning of the collaboration again between Innsbruck and UGM. Okay, thank you very much, Dr. Elizabeth Reiser and also Dr. Sofal Widat for a very great and nice discussion this afternoon. And give applause virtually for both doctors. Okay, and in Innsbruck, it's knocking the table, right?
No.
Okay. Yeah. Okay. Thank you. And I give back to the MC. I'm Sarah Yoandari, and thank you very much.
Once again, thank you for the very interesting and fruitful session, dear our honorable speakers. Finally, we are at the end of this event. I would like to ask the speakers and all the participants to take pictures so we can remember this delightful meeting. Please, all the participants who joined online, to open the camera and prepare yourself. Okay. Let me do the countdown. Is the operator ready yet? Okay. We will take the picture in 3, 2, 1. Smile. Okay. Let us repeat one more time. Let me do the countdown. We will take the picture in 3, 2, 1. Please smile. Okay. Thank you very much. Finally, on behalf of the organizing committee, I would like to express our sincere gratitude to all the speakers and also the moderator and all the participants who joined in this event. And we are also apologize for any imperfection. I hope this event will be beneficial for all of us. Thank you very much and see you in the next event. Good afternoon.
Elizabeth.
Hi, Sarah.
Hi.
Nice to meet you.
Nice to meet you. So
that was great.
Yeah. How is it in Innsbruck?
You did a great job with all these.
Oh, thank you. Yeah, I miss Innsbruck.